I'm Anthony Leeds. It's my pleasure to welcome you again to our second conversation with Professor Mike Lean from the University of Glasgow. He has, as you already know from listening to him in the past, been very influential in achieving the really good evidence on the diabetes remission programs, and also is now interested in rolling these out in other countries. Mike, thank you very much for joining us. And what I'd like to do now is to ask you to summarize briefly why you decided to undertake this work in Nepal and what the particular differences are between the way it's being done in Nepal compared to the United Kingdom.
Yes, well, this is the most exciting episode. I had soon after the publication of the direct results. This is remission of type 2 diabetes in the UK using a diet program. And there were very striking results, about half of the patients free from diabetes for a year. We published those results. And I had a phone call from a doctor, a medical doctor, who works in Nepal. Oddly enough, she was clinically trained in Scotland, but works in Nepal in a community empowerment charity. And that was a charity which was involved in helping poor communities to make the most of their resources and to improve their lot, if you like, mainly through a small-scale horticulture and clean water and things of this kind in often very remote parts of the country, but increasingly in the large urban sprawling areas around Kathmandu in the valley, where people from the villages and the hills have come down looking for the things that the West has made available for them, sadly. And in that community, they had noticed, their community empowerment agency had noticed huge numbers of people developing type 2 diabetes, being unable to work, becoming blind, losing limbs and losing kidneys as young people in their 40s and 50s. And this is leaving families without a breadwinner and placing a burden on communities. Because one of the things about Nepal and indeed many other areas of South Asia is that type 2 diabetes is very common. That's the first similarity. And the other is that communities are very strong. There's a community cohesion, including amongst the people who have moved into the sort of peri-urban sprawls and slum areas. So people were feeling very bad. The communities were feeling very unhappy, and families were being devastated by type 2 diabetes. And Nepal has essentially no money for individuals to be treated. They don't have medication for diabetes, and nothing was happening, and the patients were getting worse. So I had this phone call, could I do something about it? And so I thought, well, I think we owe it to the people of Nepal to do something about it. It's a very beautiful country. They've been very good to me in mountaineering exploits there. So I went out, met with the charity, met with doctors and nurses and some nutritionists in Nepal, and we decided that it really should be possible to adapt our diet program for remission of diabetes to the Nepal setting. Firstly, by using a diet program which is entirely made up from traditional foods, low cost and low calorie also, traditional foods, which we would then propose that they should take in a very disciplined way, just as a serious treatment for a serious disease should be, to lose weight, and to see whether we could achieve remissions of diabetes without using expensive formula diets and potentially without even using healthcare workers who are short on the ground in Nepal. And to cut a long story short, we did a pilot study amongst people with known diabetes attending a clinic in Kathmandu at the Metro Hospital, led by Dr. Jyoti there. And the remarkable thing was that these people, we gave them a diet program, which is quite simple to go away, and they did lose weight. They didn't lose as much weight as our direct participants in the UK. They lost on average about 4 or 5 kilograms at a year. At roughly 6 months, 40% of them were free from diabetes. So what we learned was 2 things. One was they are able to lose weight. 2, if they're able to lose weight and not even very much weight loss of the order of above 4 or 5 kilograms, there is a good chance that they would be free from diabetes for at least 6 months. the remission rate at 1 year was about just under 30%. So just under a third of the patients free from diabetes for an entire year if they were able to lose weight. On the basis of that information, which is now published, and additional information about what they found difficult about the program, why in some cases they found it hard to do this at home, and this is interesting in itself, and what they found useful and valuable about it. So we've got qualitative information about that. We have put together a much bigger program, a series of programs now. Firstly, going into communities, and these are peri-urban communities. They're relatively remote in some cases. No electricity, for example, to find out how many people have type 2 diabetes. And we believe from other surveys it's going to be quite a high proportion. It'll be somewhere in the region of 10 or 12% of the entire population, about 25% over the age of 40. And then to offer them a same diet program. Well, actually, we're improving the diet program the whole time once we've learned what people in Nepal find most challenging about it. And this program is now about to start, where we're going to go in and screen the community, as many people as we possibly can. It'll be thousands. We'll check their hemoglobin A1C to see who has diabetes, who has pre-diabetes, and we will invite the people with diabetes to join a randomized trial, which is going to be very similar in design to the CODIRECT trial, the long COVID trial, which basically means we're going to invite people to join the intervention with a control group who continue without intervention for 4 months. And that 4 months is going to say, are you able to lose the weight? Have you lost the weight at 4 months? And have you got significantly more remissions of diabetes? We think it will be yes. We don't know the exact numbers, of course, yet, because we haven't done it. But at that point, we will offer the intervention to all the control patients, so everybody has the opportunity to benefit from the intervention. I think in clinical research, we do need controlled trials. We need to have data from people without intervention at the same time from the same community to compare and to be absolutely sure that we have, firstly, safety, and secondly, effectiveness of a treatment. But I think we now have a responsibility with a disease like diabetes and with the treatment, which is not expensive. We have a responsibility to offer that to all our volunteers. The volunteers who come forward and say, we're prepared to help research, I think we have to help them as well. So this study is due to start recruitment in about a month's time. And at that point, we will randomize them onto the intervention group, immediate intervention or the delayed intervention group. And we will then see what proportion of people in a community can get clear of their diabetes. Now, the other big difference with this is that we're doing this in the community. They're not coming into a hospital or to see doctors. There is a primary health care centre there attached to the school. It's quite a good setup. It's very, very much primary health care, just for screening, vaccinations, and things of this kind. And that's largely operated. They have a healthcare assistant there, but also by a group of female community health volunteers. And these are women who no longer have major domestic commitments. Their children are up, and they are prepared to give time to help the community by doing things like vaccination programs, basic health education, postnatal care for women. And we've asked them, would they be willing to help with supporting people through a diet program to try and get clear of their diabetes? And the answer was very much yes, they would like to do that. Many of them have diabetes in their family anyway. So we found a huge amount of community support from this, and the group involves the health assistant who works in the community, the school teacher, and the local government. So there'd be the mayor and the local elected people in the communities. And this is very much a community-based and community-driven exercise with very little input, other than for the assessment and design of the problem, very little input from health volunteers. So they're health workers. So doctors like me are very much in the wings. A very exciting project.
It is, because also, of course, it provides clues and important information with regard to all the regions in South Asia where there's either low income or low-income countries where the possibility of using the more expensive approaches, the more expensive dietary approaches, are not going to be possible. So it has beyond Nepal, it has relevance to the entire region in both South Asia and South East Asia as well, I should imagine. When you were looking at barriers to why some people struggle a little bit to participate in it, you found out a few specific interesting things, including, I think, if I remember rightly, that you found that some people were a little bit worried about they might feel weak if they went on the diet, because of course physical activity and ability to do hard work is quite important to a lot of people in Nepal, isn't it? Being able to walk up and down hills, very important. And so
well,
what do you do about that?
Well,
Education.
I mean, you're absolutely right, Tony. We found there were quite a lot of sort of myths about diabetes, or beliefs, community beliefs about diabetes, things which generations have believed and never questioned, which actually are not correct and not helpful. So those were interesting themselves. And some of them involved beliefs about particular foods that should be eaten or should not be eaten. The issue about weakness was interesting because if people lose weight through starvation or through an illness, which could be an infection, if they lose weight in that way, they often lose muscle. They lose physical strength quite quickly, particularly through inflammation. So any inflammatory disease or infection causes weight loss, and it causes a lot of muscle loss. So people do feel weak, and they are weak. There's no question about that, and that can be measured easily. People who lose weight purely through starvation don't become weak until quite late in the disease, and we wouldn't want people to get into that position. There was a question about whether people who are significantly overweight, whether they would feel weak when they lose weight. And the answer to that is that in all the studies that have been done, there is no measurable loss of strength. And that's very important. There's been a lot of noise lately about loss of muscle mass during weight loss. Now, that's entirely normal. Part of it is because the muscle contains quite a lot of water, and during weight loss, you lose some of that water. But inevitably, there will be some mass loss, but their strength is not affected. And so it's important to differentiate muscle mass loss from loss of strength. And indeed, people with type 2 diabetes are weakened by that disease. So their muscles are not functioning normally with type 2 diabetes. And there is some evidence which says that if people with type 2 diabetes lose weight, they will actually feel stronger. And many of my patients will tell me that they've lost weight and they actually do feel stronger. And in some cases, I had one who was a bodybuilder and weightlifter, and he developed diabetes and was terribly upset about this, and lost weight and found that he was actually stronger. He could lift heavier weights. So it's interesting that there's mixed messages out there. So that myth is about feeling weaker, or the belief about feeling weaker, needs to be unpacked. And we need to counter that, because other family members will see somebody losing weight and think, oh, you're looking weaker, you're looking sick, you're looking poor. And that's just not the case. So that's a big obstacle. The other thing which we discovered, Tony, was that not just losing weight, but actually having a limited diet, having less food than normal, was considered to be likely to cause weakness, or possibly would cause weakness. So these are kind of challenges that we've met in Nepal, and I think they apply certainly across the Middle East and many Asian countries, and we see it in the UK also to some degree.
Thank you. I do know also, of course, that you've got an interest in diets with traditional food, and you have your No Doubts diet that you have advocated for those in Scotland who might be prepared to follow that. Have you any comments on that, on your No Doubts diet?
Yes, the No Doubts
I think you
diet.
follow it.
Yeah, well, I don't follow it every day, but the No Doubts diet was a slightly tongue-in-cheek approach to offering dietary advice. After the publication of the DIRECT trial, I had hundreds of emails from people saying, where do we find this diet program? What can we do? And so I got together with my dietitians, research dietitians. One of them, I think, George Tom, you've had on these programs. He was very effective. And we put together a diet program which offered the sort of discipline that we need, if you haven't got access to formula diets or you don't want to use formula diets, you can institute discipline. And we said that this would basically be 3 meals or eating episodes in the day. The first one, and this is Scottish, so picked the cheapest, easiest, most popular foods in Scotland. So breakfast, a bowl of porridge; lunchtime, a bowl of porridge; evening, do it again. Breakfast, a bowl of porridge; lunchtime, a bowl of lentil soup; and evening meal, another bowl of lentil soup. Different bowl of lentil soup with different flavors, different seasoning. But each of those meals had a piece of fruit, and they should be different pieces of fruit, and a piece of bread also. And if you add that little lot up, it comes to about 850 calories, so very similar to the formula diet. And we posted this, we called it the no doubts diet, because there is no doubt that if you follow that with about 850 calories, you will lose weight, whoever you are, wherever you are. And not everybody is willing to do it. They don't regard their diabetes as sufficiently serious, perhaps, to lose weight. But if you do that, you don't have to do it forever, of course. You do it until you've lost enough weight. And then what we recommend is to maintain the discipline with a bowl of porridge in the morning and a bowl of lentil soup or something similar at lunchtime, and then you can vary the evening meal. So you retain that discipline and always have a piece of fruit with each meal of the day and have a piece of bread as well. It's like the sort of discipline that you clean your teeth every day. Well, you're going to follow at least 2 meals a day, which are going to be pretty much the same. And that is pretty much how I do lead my life. So I have a bowl of porridge every day, very few exceptions. And at lunchtime, I would commonly have a bowl of lentil soup. That's one of the most popular foods eaten in Scotland, indeed worldwide. So there's no problem, and you can use any types of flavouring and seasoning you like. So that was what we did in Scotland, using traditional foods. And then we kind of started looking at other traditional diets. And the evidence is beginning to accrue that if people want to lose weight and to manage a disease like diabetes, there are 2 ways of going about it. One is to use a sort of named diet, a strict restrictive diet, and the low carb diets and the low fat diets and the diets which are sort of dietetically designed. There's a thing called the portfolio diet, which is another closely defined diet with actually having some additives as well, which definitely work. They're perhaps the most effective at getting weight loss, and using a formula diet is a good way of doing this. But they're not. You can't do that forever. They're not sustainable. When you look at then at what is more sustainable, a number of traditional eating patterns: Mediterranean diet, the Nordic diet, the Japanese diet, and it's possible to design a diet in Nepal, just like we did in Scotland. And that's what we did for our Nepal diet. So it's using entirely traditional foods, which are cheap, very, very cheap, no cost really at all, and which most people can get and like.
Good, thank you. So I wish you and your colleagues success in the program in Nepal, and look forward to hearing about it in the fullness of time. Just to remind viewers, there is some text underneath this window which gives you more information and some web links, and I'll certainly put in the link to the No Doubts diet and various other useful sources. So Mike Lean in Glasgow, thank you very much for talking to us about the work that has been done in Nepal and will be done in the future in Nepal. Thank you very much.
Thank you, Tony.